The value that I find from dry needling is that it helps my patients first and foremost. And I wouldn't do it if I didn't expect a positive outcome for my patients. But even for those patients that it doesn't make that improvement where they now move better, exercise better, and meet their goals right away, when the intervention doesn't work, provides me with a lot of helpful diagnostic information to further inform and refine my plan of care. So the power of dry needling to me has helped advance my ability to help my patients.
Welcome to APTA Orthopedics Podcasts, where we help you stay ahead in orthopedic physical therapy. I'm your host, Luciano Garcia, and today I'll be talking with Jon Beougher about is it time to get certified in dry needling? Don't forget to subscribe for future episodes. Let's get started. Well, welcome, Jon. I want to thank you for being here. If you can introduce yourself and tell us a little bit about yourself.
Yeah, thanks for having me. Excited to talk about this topic today. My name's Jon, and I'm the National Coordinator of Dry Needling Services for Select Medical. I live in Kentucky. I graduated from PT school in 2009. And when I first started clinical practice, I really enjoyed engaging with my patients, but I wasn't that great at getting them better. So I sought out a residency program and went through Select Medical's APTA orthopedic residency my second year out of school and joined as a faculty mentor for the next 7 years. And so residency for me was transformative into developing a framework to help my patients get better. And when I became certified in dry needling myself and added that to a framework of clinical reasoning, I found it to be one of the most helpful interventions for me to get my patients better faster, both on the value of the treatment itself and the diagnostic value it provides. And that's why I'm excited to teach dry needling and to talk about it today.
That's great. Well, give us a little background. What is dry needling?
So we'll discuss several of the nuances throughout the call, but I'm very comfortable with the APTA definition I first saw over 10 years ago. That'd be a skilled intervention that uses a thin filiform needle to penetrate the skin and stimulate underlying myofascial trigger points, muscular and connective tissues for the management of neuromusculoskeletal pain and movement impairments. Now, that sounds like a mouthful, but I think it's important to consider that when we take a needle and stick it through the patient's skin as a physical therapist in our scope of practice, that's dry needling, and it's more than just myofascial trigger points.
Oh, okay. So more than just on a tight muscle region, it can be used for other structures as well.
That's right. And that's in line with the APTA's
Mhm,
definition to stimulate not only trigger points,
mhm,
but muscular and connective tissues. That we
mhm.
sometimes there's muscles that we may want to treat with a dry needle that we can't even palpate. So the gluteus minimus or the lumbar multifidus, where the ability to palpate a trigger point might be limited, but the ability to use a needle to effectively improve the function of that tissue is definitely an option to us.
How long's dry needling been around?
So the concept began with trigger points, and that was Janet Travell back in the 40s
Oh
started
yeah.
injections
Mhm,
for trigger points. And so her work with David Simons continued to look at
mhm.
injections, both with and without actually doing the wet needling side of that. But that started in the 40s. And then in the 70s, Carl Lewitt gets kind of the term credit for the term of dry needling and refined the idea a bit of saying we can certainly do this without needing injection. So the term dry needling means that you're sticking the needle in without an injection. An injection is wet needling. So Travell and Simons did a little bit of
Oh,
both. Carl Lewitt progresses this to really dry needling. And then in the 80s, Chan Gunn was one of the pioneers to help further develop the technique and come up with applications beyond necessarily just the trigger point. And from there, we've had a lot of pioneers that have helped us develop different clinical approaches that are based on the differences in what we know about the science and the physiology and the anatomy to allow for different frameworks of application of dry needling that we see today.
okay. What are some current models for dry needling delivery? I heard you use trigger point dry needling. Is that the same as just regular dry needling?
Yeah, so it's a great question, and I think it's a really important conversation because it impacts patient outcomes and it impacts how we're going to be able to best help our patients. So this is not just semantic for me; it's something I'm very passionate about. And so I would say that not all dry needling is about trigger points, But yes, to say trigger point dry needling would always be dry needling, but you can do more than that. And so that's one of my biggest pushes now as an educator for dry needling services and as a clinician is to push for a framework that considers trigger points, but also considers underperforming muscles or muscles that
Mm.
hurt more than the objective findings suggest. Patients who have altered pain processing on the central nervous side, chronic tendinopathies as
Oh,
opposed to
chronic.
muscular
Yeah.
trigger points. So there's a lot of considerations we have utilizing the power of the needle beyond just the trigger point. So the
Okay.
historical model, how it started, based around this science and studies of trigger points and trigger point needling, and specifically trying to evoke twitch responses by needling
Mhm.
myofascial trigger points and make the muscle twitch. And that is good. That approach can be good, but that misses the ability to help everyone if we don't consider that there's more to dry needling than just trigger points. So the question on the current models, there's a lot. There's quite a bit of
Yeah.
variability, and this is typically generated by the educational provider that's delivering the dry needling course. But there's still a
Okay.
focus on trigger points, as there should be to an extent.
Mhm.
Needling along peripheral nerve pathways, targeting dysfunctional muscles,
Ah.
and focusing on movement improvement as opposed to trigger points. Activating central nervous system pathways to inhibit pain and improve, neural health. Specifically, some of the models of dry needling are targeting like autonomic nervous system benefits. So there's still a wide range, even within the physical therapy scope of practice right now, that are more than just trigger point dry needling. And the benefit is there might be the right patient in the right time that might fall into one or more of those categories.
Mhm. Mhm. For sure. Well, let's talk about certification. Does a therapist have to be certified, and what does certification involve?
Yeah, it's a great question again, and it's kind of a two-part answer. So certification in general,
Yeah.
we talk about is the educational provider. When you complete a series of courses, they will provide you the certification in dry needling, and there's lots of them out there, and those certifications that you see are based on where the education was consumed. But as far as the ability to utilize dry needling, whether you're certified by an educational provider or not comes back down to state regulation. So dry needling is still regulated at a state level. Certain states like New York and California do not allow it at all. Other states like Florida, Georgia,
Oh.
Maryland, Arizona, and most recently Washington state require some type of board approval. So this is where the terminology can get a little confusing. Some states require a license qualifier. In Florida and Georgia, they have some different requirements, but it's a similar process that you have to go through and receive board approval to needle. So it's important for a clinician to not misunderstand being certified to dry needle versus having state approval, and it's different in every single state. Every state I just mentioned, their process and their requirements is different. So as a reminder to all clinicians out there, it's always important to make sure that you are reviewing and understanding your practice act and practicing within the restrictions placed on you by your state, or in a state that allows dry needling, ensuring that you fulfill the educational requirements. So, for a clinician considering certification in dry needling, understanding their current state and thinking about future states they may want to practice in, that may alter and change how they
Mhm.
consume their education, the volume of education, and the timing for doing that.
All right. How about any risks involved with dry needling?
Yeah, so it's very safe. So we are sticking a needle through the skin. So the common issues
Mhm.
that are commonly documented and minor are bleeding and bruising, usually very minor, and then honestly soreness. And there's a debate back and forth: should that even be considered an adverse event or not? Because oftentimes when we're needling a patient, they may get sore. I would contend we don't have to make them sore in order to have a successful treatment. And in fact, I would expect the patient to move better right away after I'm done needling. And so, how aggressively the clinician manipulates the needle, there's a wide variety there between putting the needle in one time and either spinning it or adding electrical stimulation versus more aggressive manipulation of the needle we call pistoning in and out. So the safety is influenced by those factors, especially if you're needling in the area of a structure of concern, like a large peripheral nerve or a vascular structure. But being aware that bleeding, bruising, and soreness are common mild events. Oftentimes, a patient may get a little lightheaded after needling. So, again, it's not necessarily a safety concern if you're considering patient position as you're needling in patient setup. But the one serious thing that we do need to talk about that's documented in real and needs to be a consideration for all clinicians and patients is the risk of pneumothorax. So pneumothorax or collapsed lung, a single penetration of our needle, even though our needles are very small, solid filiform needles, a single needle penetration through the parietal pleura, we don't even have to hit the lung. If we go through that parietal pleura, can create a pneumothorax. So advanced training and considerations before applying needles over the lung field is vital.
Mm-hmm. How about reimbursement? Is dry needling is reimbursed with Medicare, or is it a cash basis?
So, everyone's favorite answer, it depends, right? So
Yeah,
we
I
have
bet.
two CPT codes for dry needling. So first and foremost, we have CPT codes. And so dry needling should be
Oh yeah.
billed under the CPT codes, not under other exercise or manual therapies, unless there's a specific contract that a clinician has with a payer. And I'm not speaking to the legal side, but we have CPT
Mhm.
codes. However, based on those CPT codes, it varies a lot based on both state and the payer contracts within a state. So unfortunately it depends. Some insurances do
Yeah.
cover dry needling and reimburse it. Often it will be a non-covered service that the patient will pay for out of pocket. You specifically asked about Medicare. So Medicare is tricky.
Hmm.
They include dry needling under acupuncture coverage for chronic low back pain only, but when you get into the very specific situations, it's basically not going to be reimbursed by PTs. So a PT can bill those CPT codes, but they have very specific requirements based on physician oversight and who can be applying those needles. That while they recognize the CPT codes, that would be for you in your specific situation in your state and with your payer contracts, something to consider.
Hmm. Well, how about research? What's the status of dry needling in current evidence?
Yeah, so the emerging evidence continues to support it mostly. Now, I tell everybody, as both
Okay.
an educator and as a clinician, this isn't magic. Like, it's not the cure all. It's not the only thing you need to do, and it's not perfect for everything. But we do have emerging evidence, specifically in our CPG. So I'm a big supporter and fan of all that the APTA has done to support and develop ongoing CPGs. And as the CPGs have been updated and are continuing to be updated, we're seeing more and more support for its utilization. So, specifically talking CPGs, it's included as a recommended intervention for lateral elbow pain, plantar fasciitis, ankle stability and movement coordination impairments, chronic neck pain, chronic low back pain. And there's ongoing work as these are updated to confirm where can we utilize the evidence. And what I see with the emerging evidence a lot, how can we maximize the benefit? Because a lot of historical evidence, as we've already talked about, needling trigger points or I'd say needling trigger points only. Some of those studies they don't have as much benefit as what I've seen clinically with my patients. So as we look at emerging evidence, I think what's going to be great is if we can further define how and why and where to apply the needle based on individual patient
Mhm.
considerations versus standardized needling
Mhm.
protocols, so that evidence can become more and more powerful. But as it stands today, it certainly is validated and supported by the evidence for a lot of conditions, not all conditions. And like any of our other treatments, it's
Mhm.
it's not magic. It needs to be considered as part of comprehensive care.
For sure. You mentioned a little while ago about how you expect a patient to move a little better after dry needling. Where do you put dry needling in the course of a treatment? In the front or the back, somewhere in the middle?
This is my favorite question, and this is because it's so important to me. We have so many benefits when we apply the needle. We won't get into all of them, but when we think about like blood flow and
Yeah.
biochemical reset and the benefits on the nervous system itself and the muscular ability to contract with less pain, I almost always use it towards the front end of my treatment session because I expect my patient to move better so that my properly selected and dosed exercises are going to be more beneficial to the patient, and the patient's going to be able to actually do them. So that's one of the diagnoses or benefits I've found. I know a lot of clinicians out there have patients come in, they want to exercise, but they hurt. You tell them to do these exercises and you and the patient both agree what they should do, but pain's preventing them from getting there. So I know in Kentucky we have these patients. Again, I think the correct way to say it is that the objective findings do not match subjective complaints, right? So when I
We
came out
have
of
them in Texas
Oh,
too.
you have in Texas too? Okay, yeah. So 15 years
Yeah.
ago, when I was a new clinician, didn't know what I was doing prior to residency, as a new clinician, I'd be like, oh, well, they're just a complainer, they're a malingerer. But now we know, we know from science and physiology and anatomy, there's a lot that goes on with those patients. It's real for why they're having this pain. And without getting
Mhm.
too deep into the neuroscience of dry needling, there's a lot of benefits we see in the local level. So talking about the muscle and neuromuscular junction at the spinal level. So specifically, we're talking about the afferent stimulus back to the dorsal root at the spinal level and at the central level. So the ability to activate pain inhibition pathways and allow that patient physiologically to experience less pain so that they can move better.
Mhm. What's the future look like for dry needling?
My hope is that the future is that we continue to integrate evidence on what we know on how it works and put it into treatment frameworks. So, if I can give one example of how I hope this would work, would be lateral elbow pain. So, it's in our clinical practice guidelines already, and there's a lot of evidence and research that talks about how you might needle a patient with lateral elbow pain. What I've seen in clinical practice and what we teach in our courses is when you consider the cervical spine implications or ramifications, the radial nerve pathways, and not only the wrist extensors as a whole, but each individual wrist extensor. So, extensor carpi brevis versus longus versus extensor digitorum. And then you consider the triceps, which has three different heads, and the anconeus and the supinator. So, I've just said a lot of things all at once. And so, if you're thinking back to that question, is it time to get certified in dry needling? If you don't have the ability right now to identify from either a diagnostic or a treatment value how you might target each one of those structures, we can do that efficiently and effectively with dry needling. So for me, the future of dry needling, where I hope it goes, is instead of a standardized protocol for here's what you do for lateral elbow pain, here's a standardized framework that's applied to an individual patient after you test and clear out the cervical spine and test the radial nerve and test these various structures and then determine how to apply the needles. So there's some great work. Rob Roy Martin, who's been very instrumental in helping update a lot of the CPGs, and is doing some great work. And so we'll have some exciting things I think coming forward to look at how does a clinician utilize what we know and individualize the dosing of the needling to the patient and choose how aggressively to needle based on their pain severity or based on their pain irritability. How do we determine to needle at the site of pain or a dysfunctional muscle that's contributing to impaired movement or pain, or at the central level, at the spinal level? And so these various models that we know are out there, the future, I think, is continuing to integrate those, because at the end of the day, it's all about our patients. How can we get our patients
Mhm.
better faster? And I'm convinced that any one model in and of itself may work great for one patient, but the ability to integrate those models comprehensively, following with properly selected and dosed exercises, that's when this starts to become magic.
Mhm. Any general advice for orthopedic clinicians that are right now still on the fence about pursuing dry needling training?
I do. So two things for me have been instrumental in my career. I've been a PT over 15 years now, and residency training to develop the framework, and that's the framework I apply to dry needling. The value that I find from dry needling is that it helps my patients first and foremost. And I wouldn't do it if I didn't expect a positive outcome for my patients. But even for those patients that it doesn't make that improvement where they now move better, exercise better, and meet their goals right away, when the intervention doesn't work, provides me with a lot of helpful diagnostic information to further inform and refine my plan of care. So the power of dry needling to me has helped advance my ability to help my patients. I know all of us have gone through in the past, you do a manual therapy technique, or you do an exercise, or you do an educational intervention, and afterwards, maybe you test, retest, maybe you didn't, but you're just not quite sure. Is that right? Am I on the right path? Is this going to work? Do I need to keep, how long do I need to keep doing this for? And so my push, my nudge for clinicians that are on the fence about dry needling is you can take the power and get to that end result faster. You will know this worked and now the patient's meeting their goals, or this didn't work and now I can refine my examination, I can refine my other interventions, and there's for myself, that's the value.
Hmm. Where can a clinician go to learn more about dry needling?
Yeah, so I don't know if we'll have the ability to link a couple articles that provide an
Okay.
overview of benefits and the thought process. Kind of there's some great resources out there that have been published in the last few years that are open access, just that explain a little bit more of the science of dry needling and why we might want to apply it. I'm also happy for anyone to reach out to me. Dryneedlingeducation at selectmedical.com can get you to me if you
Hmm.
have questions or challenges to anything you've heard
Hmm.
today, or want to discuss further. To think about at the end of the day, how can we help our patients?
Hmm. Yep. How about some final take to the clinic messages for our
Okay,
audience?
your patients are worth getting the best intervention to meet
Hmm.
their goals in the fastest time. And when dry needling is added to the right patient and using a clinical reasoning framework that aligns with their plan of care, you will generate better outcomes.
That's great, John. And I want to thank you for your time. I want to thank you for your expertise. It's been a pleasure.
Thanks, Luciano.
Yep. And I want to thank you all for tuning in to APTA Orthopedics Podcasts. We hope you found today's episode informative. Remember to subscribe. And until next time, stay ahead in orthopedic physical therapy.